Functional stenosis following sleeve gastrectomy is a unique complication of this procedure. It is mainly characterized by absence of any organic stricture, and the gastroscope can easily pass through this segment, but still the patient has an obstruction at the mid-gastric level. This happens like 1 to 4% of the reported cases according to the literature, and our rate is around 3%. Up to date, we successfully managed to dilate 7 patients with 9 attempts. So in 2 patients, 2 dilatations with larger balloons was needed. Here, we are doing the gastroscopy to this patient at the 15-month follow-up. He was suffering from intolerance to solids. Also, he couldn't quit taking PPIs because of the de novo reflux occurrence, and also his excess weight loss was more than 100%. And then although he didn't have any malnutrition parameters, since he was highly symptomatic, we decided to dilate him. According to the literature and also according to our experience in the last 5 years, the best balloon for this purpose, I mean, if you want to dilate a functional mid-gastric stenosis following a sleeve, is a product by Boston Scientifics, which is Rigiflex. This Rigiflex balloon is originally designed for achalasia, for dilatation of achalasia patients, but it doesn't have any, they don't have any products less than 3 centimeters in width. And actually, in a primary achalasia case, those balloons, to our belief, is very dangerous. But on the contrary, when it comes to dilate a functionally stenosed sleeve, they are the best. This is not only our idea. In most of the recent articles published on this subject, it's worldwide commonly used for the dilatation of mid-gastric stenosis following a sleeve gastrectomy. Here, right at this moment, you are seeing the incisura angularis portion, which the stenosis is occurring, and this is the proximal part, which is full of solids and some liquid, although we did this gastroscope after an overnight's fast. When using Rigiflex, it's called a pneumatic balloon, but you can also dilate it with liquid, of course. I mean, by infusing saline filled with some opaque liquid, and we are using it that way. Generally, it is recommended that the pressure within the balloon should be monitored, and this is especially true for achalasia patients in order to prevent rupture. But when doing the same procedure to dilate a functional stenosis in a post-sleeve patient, the pressure measurement is not an absolute necessity, so we didn't use it in this patient. As you can see, we are coming back and forth, and we are always able to see the pylorus. We can easily go past through the stenotic segment, so there is no organic stricture, but still the twist or the kink, or it's like a break, just across the incisura angularis. It is this anatomical difference of stomach making the incisura angularis segment very susceptible to break or twist, to tink, or to kink. Once we diagnosed the functional stenosis and decide to dilate, we prepare the patient accordingly. We do all dilatations, including dilatations for achalasia or any other dilatation, under general anesthesia and with endotracheal intubation. This is a big safety measure. The patient is intubated in supine position, of course, and then the positioning is changed for proper endoscopy. Left lateral decubitus position is preferred, and prior to balloon insertion, we gastroscope the patient one more time so that we can introduce the guide wire. You need a very long guide wire, special guide wire to do this. And the tip of our aim is to put the tip of the guide wire within the duodenum. Now I'm almost reaching the stenotic segment. This is the proximal portion of the stomach, which is dilated. Here we are gonna see the stenotic segment, which is exactly here. But apparently there is no organic stricture, and we can easily pass a 9mm scope through it. Right now we are there, and with ease and with several minor maneuvers, we're gonna be able to pass it. Yes, now this is the pylorus ahead, so we pass through it. Generally, several other options were tried in such cases. Even some surgical procedures, even without any balloon attempt, has been tried, mid-gastric resections and things like that, but all of those surgical procedures are in vain, and if surgery is absolutely needed, the procedure of choice should be a conversion to RYGB gastric bypass. Now we are already in the duodenum, and now we're gonna insert the guide wire. As you can see, the whole procedure is done under general anesthesia with proper monitoring of the patient. This is an extremely important security step to avoid aspiration. Here the guide wire is in the duodenum. And once the guide wire is in place, and once we confirm its positioning by fluoroscopy, then we will start to insert the Rigiflex. Now we are taking out the scope with special care to avoid deplacing the guide wire. So when we are pulling out the scope, we are kind of inserting equivalent length of guide wire inside, as you can see. Now the scope is out, and patient will be repositioned to supine, and fluoroscopic check confirmed the proper positioning of the guide wire, and now it's time for Rigiflex to be inserted. During the first dilatation of such patients, we routinely use the 3 centimeters diameter Rigiflex. And if the patient is not satisfied, or if we are not satisfied with the result, we will do another dilatation with a 3.5 centimeter Rigiflex. And if it doesn't work, we can do it with a 4 centimeter or 4.5 centimeter one more time. And the amount, the duration of dilatation, I mean, once the balloon is fully expanded, there is no scientifically proven duration value, but we generally use 5 or 7 or even sometimes 10 minutes of dilatation. And as I told you, we dilated 7 patients in 9 occasions, and only in 2 patients a second dilatation became necessary. During this insertion of the Rigiflex balloon catheter over the guide wire, it should be carefully handled, because when you are crossing the stenotic segment, certain amount of experience is needed. After confirming the right positioning of the Rigiflex catheter, which we will be soon shown, which is this one, the inflation of the balloon with saline starts. We generally use contrast added saline to expand the Rigiflex balloon instead of doing it pneumatically, so that the pictures are better. As I told you before, no pressure monitoring within the balloon is used when dilating mid-gastric stenosis following a sleeve gastrectomy. And once the balloon will be fully expanded, we're gonna wait 6-7 minutes like that, and then deflate the balloon. If this doesn't work, which we will understand in a couple of weeks or in a few months, and then we dilate again for another 2 times with larger balloons and using longer durations. Here, after waiting for 7 minutes, we start to deflate the balloon. We are aspirating its content now. Once it's completely devoid of the contrast and saline, we're gonna remove the guide wire and the Rigiflex altogether, as we are doing now. The last step after Rigiflex dilatation is to regastrope the patient for possible complications, mucosal tears or bleeding, etc. Also to check whether we managed to dilate properly, and then we will be done. Those Rigiflex balloons are like specially designed for this purpose, although their usage in real achalasia patients are quite dangerous if it's the first time that the patient will be dilated, because they don't have less diameter balloons, unfortunately. I mean, it's not wise to start to dilate an achalasia patient starting with a 3 centimeter diameter. These are very, very strong balloons, and they could be really, really dangerous in achalasia patients. Thank you very much for your time.